Now we're going to go to Cambodia. And I'm delighted to welcome Dr. Chris Smith, who's a clinical research fellow at the Department for Population Health at the London School of Hygiene and Tropical Medicine. And he's going to be talking about a trial to increase the uptake of post-abortion family planning methods in Cambodia.
Thank you. I'm going to move quickly. It's about the effects of a mobile phone-based intervention to support post-abortion family planning in Cambodia. It's the MOTIVE trial, Mobile Technology for Improved Family Planning. Lots of people to acknowledge, in particular my supervisor, Caroline Free. It's been a collaboration between London School of Hygiene, Tropical Medicine and Mary Stopes International. So I'm going to talk about some background, opportunity to reduce unmet need for contraception, how we developed the intervention, how we evaluated it with a randomized control trial, and a touch on the process evaluation. So contraception, methods or devices to prevent pregnancy, important for men and women to kind of control their own fertility. Lots of different methods. We can classify effective methods as associated with less than 10% 12-month pregnancy rates as commonly used. Typically, oral contraceptive pill, 3-monthly injectable, subdermal implant lasts for 3 or more years, intrauterine device or coil, again, lasts for 3, 5 or more years. 225 million women worldwide who want to avoid a pregnancy and not using an effective method of contraception. This unmet need results in significant numbers of unintended pregnancies and maternal deaths every year. A lot of women seeking abortion services will also have an unmet need for contraception, and this is the data from 2011. The driver for the project was that we saw that over 50% of clients seeking abortion services would leave with either no method or condom, and relatively low uptake of IUDs and implants. So the aim of MOTIVE was to develop, implement and evaluate an mHealth intervention to support post-abortion family planning, funded by Mary Stopes and also supported by Medical Research Council. So our hypothesis really that we could build on kind of relative success in the clinics in terms of counselling, provide additional support beyond the facility when clients have gone back to their villages, homes, 3 or more hours away often, and this additional support could increase some use of post-abortion family planning. In terms of where MOTIVE fits into the bigger sort of landscape of mHealth, it's an intervention to improve health outcomes, it's an intervention for individual patients or clients rather than the general population, touching on areas like medication adherence, pill adherence, or health behaviour change, such as a choice of one method or over another method. We conducted formative research to develop the intervention. We've got this paper, should be coming out quite soon. We looked at literature on contraception use, behaviour change, mHealth in other areas such as HIV, conducted research in Cambodia, interviews, focus groups, consultation with staff, other organisations like BBC Media Action with their Ministry of Health, and put all of this together in a conceptual framework. I'll show you in a moment. Some of the key findings from our formative research: most people had their own phone. It's predominantly rural population. Some challenges around SIM card switching, phone sharing, limited literacy, use of simple phones rather than smartphones, and barriers, typical barriers to contraception use like side effects, myths and rumours, and male opposition to use. Putting all of this together, we realised that a text-based intervention would have limited likelihood of success, and developed a voice-based intervention. The conceptual framework looks at some of these factors affecting use of post-abortion family planning, how our intervention could influence these factors, ultimately improve health outcomes, increase use of family planning, reduce discontinuation, and reduce unmet need for family planning. Final intervention looked like this. So it's designed for clients seeking abortion services, regardless of whether they adopted a method of contraception or not. Was a semi-automated intervention. So a voice message every 2 weeks, total of 6, so 3 months in total. Client could respond to the message on their phone by pressing 1, 2, or 3. The counsellor could see the response to the message. It's a real-time message, and then call the clients according to the response. So the message was here, obviously in the Cambodian language, reminded clients about contraception methods, reminded clients about availability of support. They could press 1 to request a call back, press 2 if they were fine, or press 3 to opt out. And basically the counsellors would call the clients that pressed 1, but also if they didn't respond to 3 messages. So we worked with Instead to develop the call flows and upload the messages, their product called Vervoice, very nice, free, open source software. So we evaluated with a randomized control trial. I'm pleased to say that we have published the protocol if you want to read it, download. It's a single, multi-site, single-blind RCT. We assessed clients if they were attending for abortion, aged greater than 18, had a mobile phone, willing to receive voice messages relating to family planning and not wanting a child at the present time, and then randomized to receive the intervention or standard care and followed up. Sample size of 500 participants. Primary outcome, self-report use of effective contraception at 4 months. So these methods here. I'll go through the other outcomes when I present the results. So here are the results. We assessed 915 clients. The main reason not to join the trial was either having no phone or having no time. We randomized 500 clients and we followed up 86% at 4 months. Here's the location, a bit more clustered around the peri-urban clinics, a bit more geographically spread out around the rural clinics. Collected all this baseline data. I won't go through it all, but to summarize, mainly a rural population, married, multiparous, secondary educated, age greater than 25. More than 50% were undecided about their post-abortion family planning intentions. Here are the primary and secondary outcomes at 4 months. We've got the outcomes here, intervention group, control group, relative risk, p-value. Primary outcomes, self-reported use of effective family planning, 64% versus 46%. Risk, relative risk 1.39, so a 39% increase. Confidence interval not crossing 1 and a small p-value, so it's statistically significant. Mainly driven by increased long-acting contraception, so IUDs or implants, a more than 3-fold increase. Some evidence of reduced contraceptive discontinuation. Small numbers of pregnancy and repeat abortion. Obviously, we weren't powered for this outcome, so no difference. No evidence of potential unintended consequences such as road traffic accident or domestic abuse. Here's the method mix at 4 months. A lot of pill use in the control group. It actually goes down in the intervention group. We've got increased use of long-acting methods here. Here we can see follow-up period over 4 months and increased discontinuation in the control group if compared to the intervention group. A couple of process evaluation slides. This is the response to the voice message over time, so from message 1 through till 6. Press 1 to request a callback, decreasing over time. Press 2, not require a call, increasing. Opt out here, but the highest one was call failed, so we didn't get a response to the message. We conducted interviews with clients to learn about their experience of the intervention. This is a bit more of a work in progress. Some positive things, the messages help clients remember to use contraception or some supportive aspect to them. Others not so positive. I was too busy to listen to the message, I was cooking, or it was even stressful or annoying. So we've got a mixture of responses there. So in summary, the intervention comprising automated voice messages and counsellor support, increased use of effective post-abortion family planning at 4 months. To our knowledge, it's the first trial of an mHealth intervention for post-abortion family planning. We are also conducting a Cochrane review on this topic as well, so that should be coming out in the next few months, hopefully. Further questions, what's the long-term effect of the intervention? And we are conducting 12-month follow-up. What are the active components? Again, we're looking at this. Is it replicable, scalable, cost-effective, and potential limitations of the trial, use of self-report measures, for example. So finally, just like to thank the following individuals and organisations who have contributed towards this project. Thanks very much. Yeah.
thank you so much for both of those presentations. I hope you don't mind, but I want to kick off with a question, and it is to Dr. Rodriguez, which is about why was there no difference, the 2-year, could you contextualize the results of the 2-year trial for us?
Yeah, well, there could be several reasons. One of them, I think, was that the intervention may have been too simple. We, of course, combined an IVR call with an SMS, but it may not have been sufficiently engaging, as many patients told us that they would prefer to interact with another individual, perhaps at least a few times, on the other end of the phone. There are other reasons, and I think one of the important reasons is that the adherence at baseline itself was quite high. So there was not much that could be done about raising the adherence levels. And by that I mean that there could have been a ceiling effect, because of which you cannot actually boost the adherence more than a certain percent, because you have a limit of 100% and you cannot go beyond that. And yeah, that was perhaps one of the reasons. And then there were patients who told us that they were very adherent to medication. They did not require the intervention. They suggested that we could send the intervention out to people who were actually in need, who did not take their medications well. And perhaps these were all components that impacted the results.
Thank you, thank you. Any questions, either Chris or Rashmi? Sorry, yes, in the middle there. Again, if you could wait until a microphone reaches you, thank you.
First thing I want to say to Dr. Rodriguez is thank you very much for publishing a negative result. It's great to see a really good piece of negative result. If you were going to do this again, would you go back and pre-screen your people and just select out the people with poor adherence now?
We could do a trial with patients with poorer adherence and of course see how it would work out, but that would be a completely different study. The fact still remains that the intervention did not work in people who, in most patients who do come for treatment to our center. So if there was an opportunity maybe to do the trial with, of course, there's something called funding that's required. And yeah, maybe we could try it out. Maybe we could even modify the intervention suitably to see and make it better grounded in behavioral theories as is required.
Here at the front, and then I'll take 2 questions and then you respond. There's one here at the front and then one right at the back.
So another quick question for Dr. Rodriguez. How did you overcome, I imagine in India, as in South Africa, which I know there's a lot of cases of phones being shared amongst family members. So how did you overcome the ethical problem of disclosing someone's HIV status through the intervention?
Oh, well, in order to do that, we had the intervention was completely neutral. It did not identify the disease at all. So all that it said, as I had put up on the slide in the text, was, hello, this is your good friend calling you. If you have taken all your medications the previous day, please press 1. If not, please press 2. And it at no point in time mentioned the disease at all. And the pictorial SMS was also completely neutral. So the chance of disclosing the disease because of the intervention was minimal. Our patients did report that the call was picked up by family members, by friends, but the disease, they were able to actually, in the qualitative study, it indicated that they tried to camouflage it by saying it was a call from a call center or from their network provider, or some even went to the extent of saying this is to check if my diabetic medications have been taken, if I've been taking diabetic medications right. While a lot of patients, of course, have disclosed their disease to family members because it is one of the requirements of the program that we counsel patients for disclosure. And so in a lot of circumstances, that was not much of a problem. Yeah.
At the back.
Hi, Carrie Free from the London School of Hygiene and Tropical Medicine. First of all, I wanted to thank you and your team. I think you've been really exemplary in the way that you've transparently described your intervention and also being very self-critical about why that might not have worked. And I think that's a real, really a good example of that. Just to mention, we've been looking across lots of trials at the evidence for reminders and adherence, and actually yours is now one of several trials that shows that just simple reminders isn't enough to change behaviour, and that we've seen that it's more complex interventions such as you were beginning to talk about when you were talking about drawing on wider behaviour change theory, that have shown more promising results. But it's really good to see your paper published in the BMJ, and that this is an example of something that we can all learn from. So thank you.
Yeah, I think I should also thank the journal for accepting the paper. That's very important also.
Absolutely. Anyone else? We'll go first of all to the gentleman wearing striped shirt in the middle, and then to Jean-Christophe. And then finally, I'll go to the back after that.
Thank you again for both of your presentations. This question towards Chris. What's next with your project in terms of scalability and actually integrating with existing health services?
Yeah, it's a good question. I mean, we're still delivering the intervention in Cambodia at a couple of the clinics, but it hasn't really been scaled to its full potential. So it's something I'm actually going there next week, to carry on working with the team there. But it's quite a challenge. I mean, at one point we applied for some scale-up funding, but we didn't have the results at that point. So I think it takes time to generate the evidence, and then there's still another big unanswered question around the cost effectiveness of our intervention, because it was semi-automated. There was quite a lot of counsellor involvement as well. So it's something we're looking at. I mean, I'd love to scale it up more certainly within the Mary Stopes network, which is an international organisation working in more than 40 countries, but also look to providing this sort of intervention within unlicensed, settings or other settings within Cambodia, where people might get even less access to good quality counselling when they're seeking abortion services.
Yeah, thanks both of you for a very good presentation. Mine is a sort of more technical question to you, Chris, as you are looking for, more robust evidence. I want to hear from you how you dealt with some of the difficulties to implement RCT, especially for a behavior like this, which quite easily diffuse to the neighbor. Did you consider a more quasi-experimental where you can at least control for this contamination? Broadly, sort of sharing the challenges and the difficulties that you face in ensuring that the RCT really maintain its integrity.
Okay, thanks. I mean, I think the first thing to say, the reason why we did a randomized control trial was because we wanted to. There wasn't really much evidence there. We really didn't know whether it was going to work or not. So we wanted to get that level of evidence. Like, everything else being equal, is this intervention, more effective or not? So that was one thing. And the other thing was, we looked at routine data, what was there, and we realized that a lot of clients weren't coming back to the clinic. So we couldn't use routine data. We were going to have to actively follow up clients. So we thought, an individual RCT would be the most robust way to get the answer. And I think we did it, in a reasonable amount of time and for a pretty low budget. So, I mean, although, there were some operational challenges kind of doing it within clinic settings, I think it was feasible. I think the key thing was the kind of partnership between the university and the kind of service provider. So things like doing the randomization, that was done remotely in London. So we sort of had these sort of things in place to ensure that it was kind of rigorous. but also good sort of implementation research as well. I'd be happy to talk about that in more detail afterwards if you want.
There was a question a moment ago. A gentleman raised his hand at the back. Do you still wish to ask? Excellent. And I think after that we've probably got time for one more question.
Okay, I have a question for Dr. Rashmi. Do you have a way of verifying whether a patient responding to, let's say, one for having taken medication actually took the medication, or you just have to rely on the patient's honesty?
No, we had a back end for the intervention that we had like a web interface that captured the responses to the intervention. So we had people who monitored the intervention regularly on a weekly basis, not exactly weekly, but almost on a day-to-day basis. And patients came to us every month for collecting their medications, and we contacted them if they did really badly with the intervention. So we did have a way of checking on whether they had received the call or not received the call. So it was completely computerized and web-based.
Does anyone have any more questions? Gone to the lady on the right over there.
Hi, it's a question for Chris. You said in your study you were looking at follow-up at 4 months for uptake of family planning post-abortion. Why did you choose 4 months as your time marker? What were your thoughts conceptually in designing the study on what you would see as a success as a sustained behaviour change of adopting family planning post-abortion?
Yeah, I mean, the intervention was going to last, and we were partly constrained by the timelines in the project, but 4 months is quite a good time to look at adherence, because if people are using the 3-monthly injectable, then you're going to capture people that have decided to discontinue that particular method. Also, a lot of discontinuation occurs within the first few months. So if somebody's kind of still on a method at 4 months, there's quite a good chance that they might continue. And the intervention itself lasted 3 months, so we wanted a bit of a washout period before we started doing the follow-up. The other thing to mention is we are doing 12-month follow-up at the moment. But we also wanted to get high rate of follow-up, and what we've noticed with the 12-month follow-up with it has gone down, compared to what we've managed to do at 4 months because of this problem with SIM card switching and things. We've simply lost contact with some of our trial participants. So there were some kind of, I guess, contraceptive type reasons for doing it, but also pragmatic kind of trial related.
Thank you very much. I would like to finish by retweeting a tweet and a comment from Caroline Free at the back there that common wisdom is that reminders work, reminders change behaviour, but simple reminders may not be enough to change behaviour because it's more complex than that. So thank you very much for my speakers for sharing the evidence from their interventions. I very much enjoyed that session. Thank you.